Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
All right, get ready to dive deep into SVTs, those rapid heart rhythms we see in the ER all the time.
Yeah, we're going to be looking at how to manage supraventricular tachycardia, especially for those of you working in emergency medicine.
We'll be focusing on the 2019 ESC guidelines.
They offer a fresh perspective, going beyond the typical ACLS algorithm.
Kind of like a new lens for looking at SVT management.
Exactly. It encourages a more in-depth way of thinking about each step in the ER.
Okay, so let's say you have a patient with a heart rate that's through the roof.
First things first, we check their stability.
Right. Can they talk? Are they pale? Sweating? Any signs of shock?
That initial assessment is crucial.
It dictates how quickly we need to act.
Absolutely, and the ESC guidelines emphasize that patient stability is key.
So if the patient is unstable,
Hypotensive, altered mental status, you name it.
then both the ESC guidelines and the ACLS algorithm agree.
Synchronized cardioversion is the way to go.
We have to restore that normal rhythm ASAP.
Sometimes there's no time for anything else.
Synchronized cardioversion, just for clarification, is like a controlled electrical shock to the heart
Precisely. Timed perfectly with the patient's rhythm.
to get things back on track.
And the ESC guidelines are clear that if there are delays with the cardioversion, or if the first attempt fails,
Intravenous amiodarone should be considered.
right, they suggest a 300 milligram bolus over 10 minutes.
Interesting. And then followed by a 150 milligram infusion for the next 6 hours,
Yes,
which is a bit different from the ACLS 300 milligram bolus, right?
that's right. The idea behind this approach is to gain faster and more effective rhythm control.
Especially in those time-sensitive situations.
Exactly, while also managing potential side effects.
Now, for a stable patient, the ACLS algorithm points us toward vagal maneuvers.
Ah, yes, the vagal maneuvers.
Not always the most fun to perform, but
They're techniques to stimulate the vagus nerve.
to slow down that heart rate,
The Valsalva maneuver is a classic example.
where you bear down like you're lifting something heavy.
It might not be pretty.
But if it works.
It works.
The ESC guidelines recommend a slightly different approach to the Valsalva.
Oh,
Doing it lying down with your legs up.
interesting. They say that can increase the success rate,
They also mention carotid sinus massage as a vagal maneuver,
but we have to be cautious with that.
especially in patients with carotid artery disease.
For sure, always prioritizing safety.
So if vagal maneuvers don't work, the next step in the ACLS algorithm is adenosine.
Now, adenosine is a fast-acting medication.
It has an incredibly short half-life.
It works almost instantly, blocking specific electrical pathways in the heart.
To give the normal rhythm a chance to take over.
A quick reset for the heart's electrical system.
The ESC guidelines recommend starting with a 6 milligram bolus of adenosine,
Correct?
followed by 12 milligrams if needed,
And they really emphasize administering it rapidly.
through a large vein, like the
That
antecubital,
rapid central administration is important
so it reaches the heart quickly and efficiently.
and increases the chance of successful conversion.
So with vagal maneuvers, adenosine, or even amiodarone.
The goal is to get that SVT converted back to a normal sinus rhythm.
But before we jump into treatment,
We need to figure out what kind of SVT we're dealing with.
and that's where the ECG comes in.
Our window into the heart's electrical activity.
It helps us differentiate between the different types of SVTs.
AVNRT, AVRT, atrial tachycardia.
So let's talk about ECG interpretation.
It can definitely feel like a puzzle sometimes.
Thankfully, the ESC guidelines provide some tips,
We start by looking at the QRS complex.
which shows us how long it takes the electrical impulse to travel through the ventricles.
A narrow QRS complex usually means the SVT is coming from above the ventricles.
And a wide complex,
That might suggest ventricular tachycardia.
which is a whole other talk.
Exactly.
Then we focus on those P waves.
The P waves represent the activity in the atria.
Their relationship with the QRS complexes is key.
It tells us a lot about the type of SV2.
In AVNRT, for example, you might see retrograde P waves,
Meaning they come after the QRS complex.
and in AVRT.
They might be hidden within the QRS complex.
These subtle differences can really guide our treatment.
It's like piecing together a puzzle, isn't it?
Each piece of information helps us understand what's happening in the heart.
And that understanding is essential for making informed decisions.
Absolutely, it's what makes emergency medicine so challenging.
When so rewarding.
I couldn't agree more. But I think our listener could use a break before we get into the specifics of each type of SVT.
Definitely, we'll be back in a flash to explore those fascinating rhythm disturbances.
So stay tuned.
We'll dive deeper into the world of SVTs. So are you ready to tackle some specific types of SVTs?
Absolutely. Let's start with the most common one we see in the ER.
AVNRT.
Yes, AVNRT, or atrioventricular nodal reentrant tachycardia,
Right, it's like a tiny electrical loop in the heart going crazy.
causing the heart rate to skyrocket.
Exactly. In AVNRT, there are two pathways in the AV node.
And the electrical impulse gets stuck in a loop between them.
And as it circles around, the heart rate increases.
The ESC guidelines really highlight the importance of differentiating between typical and atypical forms of AVNRT.
It can definitely impact how we manage it.
What's interesting is how these differences show up on the ECG,
Right, with typical AVNRT, you often see those retrograde P waves,
right next to the QRS complex.
almost merging with it,
But in atypical AVNRT, the P waves can be harder to find.
hiding further away from the QRS.
We talked about how vagal maneuvers and adenosine can be effective in breaking those electrical loops,
Yes, but the ESC guidelines also mention calcium channel blockers.
like verapamil or diltiazem.
Exactly, but they emphasize using them only in stable patients.
Makes sense. They work by slowing down the conduction of the electrical impulses,
Through the AV node.
which can stop the reentrant circuit.
Precisely.
But we need to be careful with these medications in patients with heart failure or low blood pressure.
Definitely. Using them in those situations could make things worse.
And just like with adenosine, the ESC guidelines recommend going intravenous with verapamil or diltiazem
For quick and efficient delivery.
if medications aren't working or if the AVNRT keeps coming back.
Catheter ablation can be considered as a long-term solution.
It's like sending a tiny electrician to fix the wiring in the heart.
A catheter is inserted, guided to the heart.
And then radiofrequency energy is used to ablate the area causing the short circuit.
Right, it destroys the tissue causing the problem.
But it's important to note that catheter ablation should only be done by experienced operators
Absolutely, in specialized centers.
to minimize risks and complications,
The ESC guidelines even offer recommendations for different ablation techniques.
to ensure the best outcomes.
Okay, now let's move on to another common SVT.
AVRT.
Yes, atrioventricular reentrant tachycardia.
This one involves an extra electrical pathway,
That's right, an accessory pathway between the atria and ventricles.
creating a shortcut for those electrical impulses.
Imagine an extra lane on the highway that allows cars to bypass the usual route.
And that shortcut can really make the heart race.
Especially when an impulse gets trapped in a loop between the normal pathway and the accessory pathway.
AVRT can manifest in a couple different ways.
Orthodromic and antidromic,
Orthodromic is more common,
where the impulse travels down the normal pathway,
and back up the accessory pathway.
which usually results in a narrow QRS complex on the ECG.
And both vagal maneuvers and adenosine can be effective in stopping it.
But antidromic AVRT is a different story,
The impulse travels down the accessory pathway and back up the normal one,
often leading to a wide QRS complex.
which can look a lot like ventricular tachycardia,
It can be tricky to differentiate between the two.
especially with a wide complex on the ECG.
We rely on our ECG interpretation skills and look for clues.
The ESC guidelines provide some guidance here.
Sometimes in antidromic AVRT, the shape of the QRS complex is slightly different,
Or we might even see subtle changes in the QRS with each beat.
called QRS alternans, which can indicate AVRT,
But in tough cases, an electrophysiology study may be necessary.
to make a definitive diagnosis.
Now, with antidromic AVRT, we need to avoid certain medications.
Medications like verapamil, diltiazem, and even adenosine,
They could speed up the conduction down the accessory pathway.
and potentially lead to dangerous rhythms.
So what's the go-to treatment for antidromic AVRT?
The ESC guidelines recommend intravenous procainamide for stable patients,
It works by slowing down the conduction through that accessory pathway.
helping to break the reentrant circuit.
And if procainamide isn't effective,
Intravenous amiodarone is also an option.
and just like with orthodromic AVRT, catheter ablation of the accessory pathway, the gold standard treatment.
If medications fail, or if the patient has recurring episodes.
Referrals to experienced electrophysiologists are key in these cases.
Now, before we move on, there's a subtype of AVRT that deserves some attention.
Wolff-Parkinson-White syndrome.
Yes, WPW.
It's a pre-excitation syndrome
where the accessory pathway is present from birth.
and can lead to a variety of arrhythmias, including AVRT.
WPW can sometimes increase the risk of life-threatening arrhythmias.
especially during physical activity.
So the ESC guidelines have specific recommendations for its management.
For patients with symptomatic WPW, catheter ablation is generally recommended.
To eliminate the risk of those dangerous rhythms,
But for asymptomatic patients, the approach is more nuanced,
a thorough risk assessment is needed.
taking into account the patient's age, characteristics of the pathway, and their level of physical activity.
It's about weighing the risks and benefits of ablation versus monitoring.
And for high-risk patients, ablation is often recommended even without symptoms,
For example, patients who have experienced fainting spells.
or have a family history of sudden cardiac death.
It's remarkable how the ESC guidelines provide such comprehensive guidance.
They help us make informed decisions and ensure the best outcomes for our patients.
It shows the power of ongoing research and collaboration.
But speaking of complex arrhythmias, we haven't even touched on atrial tachycardia yet,
Oh, you're right. That's a whole other fascinating area of SVTs.
and one that requires our attention.
Yeah.
All right, let's talk about atrial tachycardia, or AT.
This one can be a bit trickier to pinpoint than AVNRT or AVRT.
It seems to have a mind of its own,
What's interesting about AT is that it starts in the atria.
but it doesn't involve the AV node in the same way.
Right, it's not a re-entrant circuit like the others.
Instead, it's a single focus in the atrium that's firing off impulses like crazy.
Like a rogue pacemaker gone haywire.
And that makes it look different on an ECG.
It can vary a lot from one patient to the next.
The ESC guidelines mention that those P waves in AT can be really subtle.
Sometimes almost impossible to distinguish from the T waves.
It's a challenge for even the most seasoned ECG interpreter.
And to add to the complexity, the QRS complex can be narrow or wide.
Depending on how that electrical impulse is traveling.
It keeps us on our toes, that's for sure.
So how do we even begin to manage AT with all these different presentations?
Well, as always, the first step is assessing the patient's stability.
If they're unstable, we go straight to synchronized cardioversion.
No time to waste.
But for stable patients, we can consider medications.
To control the heart rate or convert the rhythm back to normal.
The ESC guidelines offer a slightly different approach to medication choices for AT.
Right, for stable AT, beta blockers are often the first line of therapy,
They slow down the heart rate and reduce the excitability of that rogue focus.
calming things down in the atria,
But the guidelines also mention calcium channel blockers as an option.
especially if beta blockers aren't effective or can't be used.
And here's where things get interesting. The ESC guidelines suggest intravenous ibutylide,
As another potential tool for converting AT.
particularly in patients without structural heart disease.
Abutylide is a unique medication,
It works by prolonging the heart's electrical recharging period.
which can sometimes break that abnormal rhythm.
But it requires close monitoring, especially for QT prolongation.
Absolutely, safety first.
And of course, if medications don't work, or if the AT keeps recurring,
Catheter ablation is a definitive treatment option.
like with AVNRT and AVRT, referral to an experienced electrophysiologist is crucial.
They're the experts in this procedure.
So we've covered the three main types of SVT.
AVNRT, AVRT, and BAT.
It's amazing how they each have their own unique features and challenges.
And how the ESC guidelines provide such tailored advice for managing them.
It really highlights the importance of staying current with research and guidelines.
To ensure we're providing the best possible care for our patients.
But it's important to remember that these guidelines are a framework.
Not a rigid set of rules.
Every patient is different, and we need to consider their individual needs when making decisions.
That's a crucial point. There's no one-size-fits-all approach in the ER.
Absolutely.
Mhm.
So we've talked about acute management of SVT.
But what about the long-term picture?
That's a great question. We're seeing more adults with congenital heart disease.
And that will definitely impact how we manage SVTs in the future.
These patients often have unique characteristics.
That require a specialized approach.
It's definitely something to keep in mind.
As we continue to learn and adapt in the world of healthcare,
It's a fascinating field that's constantly evolving.
I want to commend all of you working in emergency medicine.
You're doing incredible work managing patients with SVT and other cardiac emergencies.
They're the real heroes.
We hope this deep dive into SVT management has given you some valuable insights to take with you.
Stay curious, stay engaged, and keep up the great work.
Until next time.